Hi, everyone. Thank you for staying for the last session. We appreciate you riding out with us. My name is George Koch. I'm an assistant professor of urology at The Ohio State University, a small school in Columbus.
And my name is McCammon at Eastern Virginia Medical School.
And we'll be doing the key takeaways for lower urinary tract reconstruction. So for reconstruction, as you know, a lot of you know in the room, it's kind of a potpourri of a lot of different disease processes and a lot of different organs. So we really tried to group these into some fun themes to keep it interesting for our last session. So what we're going to start off with is what was old is new again. A search for alternative to buccal continues. As most of you know, reconstructive urologists will put buccal mucosa on almost anything, and it almost always works. So I was really intrigued by a bunch of posters that looked to find an alternative source of buccal, and we'll talk about that a little bit. So our first paper was a pretty small series using bladder mucosa that was actually harvested with a holmium laser transurethral. So these were 13 patients with strictures greater than 2 centimeters, and the authors approached the stricture during urethroplasty, incised the stricture, and then put the scope in after incising the stricture. Harvested their bladder mucosa, kind of using almost a nucleation or HOLEP technique, and then use that as their graft. These patients were followed out to at least 12 months and did relatively well for kind of an old/new technique, with 84% without recurrence at those 12 months, and then this group also took their bladder mucosa and looked at it histologically and found that they were able to keep healthy, intact urothelium and a healthy submucosal layer without damaging these layers. So, Dr. McCammon, I have not used bladder mucosa before, but I know that it's a technique that has previously been described. I was just wondering if you might talk about it a little bit.
You say that because I'm older and think maybe I have the use of it.
Much older.
We've never used bladder just because I thought the invasiveness of harvesting it. But I think this is an interesting study because you're able to harvest it in a different fashion. So this would be an opportunity to maybe start using it in that aspect. The results, though, from the older studies were never bad. It was just the extra work of having to get it. It was usually used successfully in the bulbar urethra. If they used it more in the penile urethra or as a staged procedure, it did not work.
Okay. And that was kind of the discussion in this session as well, is that if you were going to have problems with it, it seemed to become a little nodular, kind of at the meatus for hypospadias repairs. The next study we'll look at, next alternative, was staged mesh graft urethroplasty. So these were hairless skin grafts taken from the groin in 108 patients with a 2-stage graft repair. The median length of these strictures is quite long, 15 centimeters, and the follow-up was also quite long, out to 63 months. Recurrence-free survival was 60, which is obviously smaller than you'd expect for a lot of urethroplasty techniques, but again, 15-centimeter strictures are long and pretty difficult to deal with. And most, or at least a majority of the patients were pretty satisfied with the result. This is another one where for buried penis, we skin graft all the time, but skin graft has kind of gone out of favor for a lot of urethral strictures, and you'd imagine if they're 15-centimeter strictures, and they may or may not be associated with LS, and just wanted your thoughts on skin grafts.
This is interesting because I presented a paper just like this when I was a year younger than you. So when I was a fellow, we presented our data. Now, it was only like 18-month follow-up, so the results were great. But once we really followed them long-term, they were about 50%. So there's no question we have to be adaptive in reconstructive urology, and sometimes we're going to have to consider options that maybe aren't as successful when we don't have the tissues.
Mm-hmm. Our last alternative to buccal is another skin graft, but instead of a partial thickness skin graft from an extragenital region, this was Dr. Kulkarni's group in Pune, India, who used a spiral perputial graft for long urethral strictures. Again, the stricture length was 16 centimeters in this group. I actually have been lucky enough to have the opportunity to go see them do it in Pune, and it says 134 minutes, and they actually mean that. They are quite fast and facile at taking this graft. And actually, I saw them even do it on patients who had previously been circumcised if they had a couple centimeters of redundant penile skin. Their median follow-ups relatively short for such a long stricture, and recurrence was observed in about 10%. Again, you worry about such a long stricture and the potential for LS, and now we've gone from extragenital skin to genital skin, where lichen sclerosus may have even more of an impact. But what are your thoughts on this one?
Yeah, obviously, that cannot be done on a lichen sclerosis patient. It'd be interesting to know why they didn't use buccal in a lot of these patients, and was it because they had tried buccal in the past or something? I think we, again, have to be adaptive. This makes sense, but again, you're going to need longer follow-up than the 19 months or 16 months that they have.
Yeah, absolutely. So this is something they talked about during the session and in person in Pune, but they had a problem getting an anesthesiologist who was willing to allow them to do an oral harvest during the COVID pandemic, which is kind of, and most of their patients are done under spinal as well, so without a protected airway. So that was kind of where the innovation came from for this. So now, after looking at all three of these, my big question is, we have so much success with buccal. We know that we can reharvest the same site. We've got studies that prove that that's a viable option. We can take lingual, we can take labial. Do we need to keep looking for an alternative to oral mucosa?
I think it's good for us to continue to look, because that's the only way we're going to progress and get better. I think buccal is great, and we use it on almost all patients, but there is a commercially available product now in Europe that's being used, and I've been working with one of our organizations in town with an amniotic membrane. So I think for us to continue to progress and move forward, I think we do need to find something else, although it's got to be proven to be better than buccal.
Thank you for that. I appreciate it. Next, another urethral stricture and kind of another unresolved debate in GERS and in the reconstructive community, but how do we follow these patients? So this first paper I thought was really, really interesting during the podium session this morning, and it looked at the group out of Germany, Dr. Fisch's group, with a large proportion, or a large number of men who underwent anterior urethral augmentation, urethroplasty. They had both staged and unstaged procedures, and they looked at what their disease-free survival would have been based on how they followed them. So in kind of the most conservative group, they looked at patients who they could either get on the phone or they could abstract from their medical record. The realistic scenario was just patients that they could get in person or on the phone, and then the last scenario was if they haven't called, then there's not a problem. And they looked at the different levels of disease-free survival they had, and I found this a really interesting paper, because I think it really points to the fact that if we're going to be following these patients for a long time, which we need to in stricture disease where the outcomes for reconstruction generally are pretty good, then we need to really kind of uniformly look at how we're following patients.
No, I agree completely. We have to get better, and I'll applaud the Terns group, because they've been really instrumental in the United States about moving that research forward and really giving us better long-term outcomes.
Mm-hmm. And I think modeled after the Terns group, this was the European Urological Association. Their young reconstructionist group did an interesting study. For those who don't do a lot of qualitative research, this is a Delphi study. So this is a study where you take a group of experts, you ask them a series of questions, and then after they've given you the results, or after they've given you answers to these questions, you actually tailor the questions even further. You send them the set of results de-identified so that they can see what their peers have also said on kind of your phase one, and then you ask your kind of tailored questions, and it's a way to generate consensus. So this group looked at the best way to follow urethral strictures and kind of what the experts in the field were looking at to look for agreement as far as what might be the best parameters to look at. And obviously, recurrence-free survival was atop this list, as was patient satisfaction, and that was just subjective. Hey, are you doing happy, or are you doing okay? And then finally, whether there was a difference in patient-reported outcomes were kind of the three things that they looked at, and they suggested that the consensus, at least in their group, was that that if we're following strictures, these should be kind of the backbone of how we're following people.
Yeah, I think that's great. I mean, I agree 100%.
So, kind of after thinking about both of those studies, how strict is your protocol, and are you following based on symptoms or how well people are doing? Do you tailor patient to patient?
I think it depends on the patient. A lot of the times depends on what we do, for sure. That will tailor my protocol to that. You also have to address where the patient lives and their follow-ups that way. So if they don't live locally, we'll have a phone call or a telehealth appointment, but we have to rely on their urologist sometimes as well, which makes it harder. But I think especially people my age are getting better at our follow-ups. Before, the follow-up was if we haven't heard from them, they must be doing great, because of course they would call. But we all know that that's not correct, and that's not the right way to follow them.
Absolutely, absolutely. And do you routinely perform cystoscopy, or if patients are doing okay, are you?
You're going to make fun of me, but yeah, I still do a cystoscopy at about 6 months. And I do tailor my follow-up a little bit on that, depending on what the urethra looks like, especially if they're local patients. I may change my follow-up a little different if it looks really good compared to if I'm a little concerned.
Yeah, no, you may laugh at me, but I also do a lot of cystoscopy. But I essentially, at least the data as I read it says that most patients are going to recur in the first year. So if I felt like it was a high-risk urethroplasty or patient, I usually cysto them earlier in that year. And if not, once they get to their year, I cysto them, and then we just follow based on, feeling after that. Yeah. All right, so another thing that kind of the reason that most reconstructionists continue to have a job is the presence of radiation. I'm sorry if there are any oncologists in the group, but we always are kind of looking for different ways to address.
Can I just interrupt you for a second?
Absolutely.
What's the most reliable way is not let them have radiation. That would be the best way for us to not have to deal with this anymore.
It certainly would. It certainly would. But I do remind my patients who come in for these kind of conditions that cancer curing, life-saving therapy in a lot of instances, and we will kind of work with it after that. But this paper was an interesting one. Over the last year or two, I think if you're not doing reconstruction, this may be a surprise, but a lot of thought leaders in the field have started to discuss whether we can start putting buccal grafts actually on radiated strictures, which was, previously kind of a dogmatic hard no. And there was some good data out of Dmitry Nikolovsky's group in the Journal of Urology that had pretty good outcomes with it. This is kind of a counterpoint to that. Dr. Rourke out of Canada looked at 141 patients with radiation-induced stenosis, and he split his patients into those who had an excision and primary anastomosis, a classic EPA, which is generally the kind of the classic teaching for radiated strictures, or those with buccal augmentation. And at a median follow-up of 83 months, he actually found that the only predictor of urethroplasty failure was a buccal mucosal augmentation versus anastomotic repair. Are you still doing anastomotic repairs, or are you kind of dabbling with augmentation?
I have not really jumped into the augmentation on these groups, so I agree with Keith completely. I do almost an excision and primary anastomosis on everybody. I've always wondered where the graft would go sometimes when we were going so posterior, and how the graft would take. So I've strongly pushed for EPAs on that group.
Mm. Yeah, it's interesting. I have been part of kind of the debates and discussions, and I think I'm still on the anastomotic side, but it's tough. When you look at some of the data out of the group from upstate, they do okay. Do you still use a gracilis flap for kind of bolstering the repair?
No, I usually, if it's an excision and primary anastomosis, no. I've used it a couple times when the tissue was unhealthy, but most of the times I will not do a gracilis in this group. Obviously, rectal urethral fistulas are different
ballgame, yeah. And then one study that really gave me honestly some comfort was this health-related quality of life outcomes study out of the University of Utah, Dr. Meyer's group, that looked at a prospective cohort and their patient-reported outcomes before and after urinary diversion for radiation-induced injury. And they found that in these 39 patients, overwhelmingly, most quality of life metrics trended toward the positive in folks that had a urinary diversion for radiation-induced injury. And I really want to go back and show some of my patients this, because I sometimes feel like I'm counseling pretty hard that we should be doing a urinary diversion for some of these devastated outlets, and then the day of surgery comes, and I'm always like, oh man, I hope I push this patient into the right thing. So this was pretty comforting data for me to see.
Yeah, this is a very difficult group of patients, as you know, and it's hard for them to get to the point where they have to sometimes do these big operations just to get their quality of life back. But most of the time, they're very happy and thankful they went through it.
Mm-hmm. Absolutely. Next up, some exciting advancements in the world of male stress incontinence and the artificial urinary sphincter. We have what I think some people will be surprised to find is the first multi-institutional prospective trial of patient-reported outcomes and success outcomes for artificial urinary sphincters. If you look at the artificial urinary sphincter data, it's old and it's reliable. We've got long follow-up for these patients, but it is generally retrospective and single institution. This was a single-arm prospective multi-center study that looked at outcomes and patient-reported outcomes for patients with an artificial urinary sphincter for male stress incontinence, and the results agreed with what we already knew. But I think they'll be helpful as we look to potentially innovate in the space that we now have really robust, high-quality baseline data. Essentially,
I agree. This was nice to see that it actually does mirror what we expect and what we usually tell our patients.
Mm-hmm. Now, a group that may take advantage of some of that baseline data is this group. This is the SOFIA study, and this was a study of an electronic artificial urinary sphincter called the UroActive, made by the Euromems company out of France. Now, this was a feasibility in human study. This is not something that you're going to be able to get off the shelf anytime soon. But in these 6 patients, the primary outcome measures were the rate of successful activation and the rate of explantation at 6 months and 1 year, and the study was successful from that standpoint. I'll save this question for you. I just showed 2 studies, one that showed the artificial urinary sphincter does a really great job, and another study that says we're trying to replace it. Do we need an electronic AUS?
I think it's nice. I mean, obviously, there's some patients that we can't do an AUS on if they did Parkinson's or things along those lines. So those are obviously good candidates for this. The other, one of the advantages they talked about last year at this meeting was they can actually lower the pressures at night. So maybe that'll help with urethral atrophy over time. Obviously, time will tell. They're hoping to start their trial in the United States sometime in this year. So once we get that data in 3 years, whatever, hopefully we'll have an idea.
Yeah, I couldn't agree more. I was really excited by this. I really felt like, I've always felt like I have a group of patients who I really feel could benefit from an artificial urinary sphincter, but I worry a little bit about their hand function. Sometimes you worry about them forgetting to cycle the device, or we've got patients who refuse to cycle the device. So I really think that there is room for an AUS that can both be used by folks who may not have the strongest hands, and also folks that could use help from things like an app or machine learning, or the data collection that we could get off of one of these. Finally, and this will be quick because we have hit our time, but this is minimally invasive techniques are taking hold, and at least in lower urinary tract reconstruction, with laparoscopic suturing devices through sheaths in the urethra, and especially the use of the robot, I'm finding more and more that the techniques that I learned in fellowship almost seem like they're going to become outdated. So I was really interested in some of the robotic options for posterior urethral pathology. Now, these are all small studies. One of them's a video, one of them's a case report. But it really got me thinking, and I'm going to see if I can play this video, and I really hope it's not too loud. Oh, it's not loud at all. That's great. This is a team that from the University of Washington that actually mobilized the urethra completely from below in a pelvic fracture, but then passed it up, as you see, in through and actually sutured their anastomosis robotically. Where I found this really interesting, and we'll skip this data just to get to the discussion, was, do we need to examine some of the steps of like a posterior urethroplasty now that we do have these minimally invasive options that could allow us to potentially avoid things like corporal splitting or a new pubectomy?
I think this is great. I mean, I went into reconstructive urology because I never put a laparoscopic port in, so I thought this would never happen in our field. Thank goodness I'm older because I still have, this is past me, obviously, but I do think we need to continue to push that envelope, continue to do these things, because this will help our patients who have radiation. I mean, there's so many other aspects. So I think this is great and applaud them for what they're looking at and doing.
Yeah, I've been a part of some of these cases actually, and it is really encouraging to know that there are cases where previously you said, oh, man, I know how to do a posterior, but I'm not sure that I can get that gap closed, and potentially with things like mobilizing the bladder or being able to suture intracorporeally, we may be able to take some lifelong SP2 patients and get them back through their urethra again. Thank you so much for your time, Dr. McCammon. I really appreciate it, and thank you all for staying.